Welcome to Ask Sid, the official podcast for Sydenham Clinic. Today I come to you from our flagship location here in Beverly Hills. I am so thrilled to bring different guests onto the podcast so that we can talk more about our 7 pillars of health, and we can go deeper into your genomics, your gut health, your hormones, your sleep, your nutrition, psychology and physiology. So let's bring it on. Welcome back to Ask Sid, the official podcast for Sydenham Clinic. And today we're going to talk about a very important topic. And this is not only important for you, it's important for your daughter, it's important for your sister, it's important for your wife. And we're going to talk about endometriosis. We have Dr. Kerin Orbuch, who is the global authority on endometriosis. We're so fortunate to have you. Thank you so much for coming here today.
Oh, it's my pleasure. I'm really looking forward to our conversation.
Yes, and your book, Beating Endo, it was an eye-opener for me too. And the way we met was because we referred one of our patients to your office, and we usually go along with our concierge members to help them hold their hand because they're scared. And sometimes having your primary care team in the room helps you ask the right questions. But we came back blown away by the compassion and the approach you and your team take towards endometriosis.
Yeah, I think it's so important because patients with endo have been suffering on average of 8 to 10 years. And they've seen on average of 8 doctors over the course of the decade. And they're just not believed. Their pain isn't believed. And it's just such a devastating disease. And so we approach it from the first phone call when they call Iris Wings. We approach it with compassion and kindness, and we model our office like the Four Seasons, meaning we hold hands, we listen, we don't interrupt, and we're a safe space for our patients to allow the healing. And we specialize in pelvic pain related to endometriosis in a holistic East meets West approach, multidisciplinary, treating the root cause, not band-aiding care.
Yeah. And you just said this fleetingly, but just to pause on just that one, that it takes you 8 to 10 years to get a diagnosis of endometriosis. You have to go through 7 or 8 doctors who misdiagnose you. I mean, we're in 2026. Nobody should be suffering with that amount of pain. And I think let's start by first telling everybody what is endometriosis.
Absolutely. I'm going to start with the symptoms, and then I'll get into the definition because I think it'll make a lot more sense for those out there listening. And so endo is an inflammatory systemic disorder, a disease that's so common. About 8 to 10% of the population. It's like 200 million worldwide. And it's mistakenly thought of as a menstrual disorder, meaning it only affects the pelvis, it only affects our reproductive organs, but that is so far from the truth. So it's a systemic inflammatory disorder, and it can cause a whole host of symptoms across all organ systems. So from a gynecological perspective, those can have painful periods, experience painful sex, heavy bleeding, fertility issues. Endo is actually responsible for 40% of unexplained infertility. Most endo patients present with intestinal gut issues, so spanning from constipation, diarrhea, being diagnosed with irritable bowel syndrome. Bloating is another big one. Plethora of endo patients have a lot of urological issues, like feeling like, oh, I have a urinary tract infection, but cultures often are negative. Urinary urgency, like, oh my gosh, I gotta go. Or urinary frequency, like frequently going to urinate. Overall, they report just tons of fatigue and exhaustion. So you can imagine they're going to the GI for the gut issues, or they're going to the gynecologist for the GYN issues, they're going to the urologist for the urological issues. They're reporting the fatigue to the internist. So no one's putting together and asking body-wide systemic questions. So scientifically, what endo is when you have cells that are similar to the lining of the uterus, known as the endometrium. It's not identical, it's similar to, and those cells are found external to or outside of the uterus. And there's a study, an Italian study, that actually showed that fetuses there was autopsies done on fetuses, and they found that 9% of female fetuses had endometriosis. So that number is not too dissimilar than what we quote in the general
Oh.
population. So it points to either a genetic link, like meaning it could come from the mom's side or the dad's side, or there's exposure in utero to, we know by dioxins, which are byproducts of bleaching, can then induce endometriosis. So there's probably many other chemicals that are then inducing endometriosis within the fetus. So, even if someone's getting picked up 8 to 10 years after symptoms started,
Mhm.
chances are they had a lot of symptoms before those 8 to 10 years, meaning they were the kid who's 5 years old who just like has a tummy ache. They are oh, they're a precocious teen, or they're a precocious kid who then becomes a precocious teenager, but it's not. They're symptoms of endometriosis. So
Can we
this,
just pause here and really like, so endometriosis is not only a disease in menstruating women. It can start out in kids and it shows early signs.
yes.
So we should take it seriously when our kids are saying my tummy hurts or they have different aches and pains or they're emitting signs like closer to puberty, or at what point do you say I want to take you to the OBGYN and get you diagnosed?
Mhm,
Because we want to come to how you diagnose it.
mhm,
And obviously it must be so hard to diagnose in a child because you can't do a physical
mhm.
or I don't know, like how do you diagnose
So
in a young girl?
so one of the first things I do is I get family history.
Mhm.
So meaning I get family history from mom's side or dad's side. I ask them, "Mom, like, does anyone in your family have gut issues or painful periods?" If they say, "Oh, yeah, her aunt has endometriosis," right then and there, I know that there's a 70 to
Ooh.
100% likelihood that that girl in my office has endo. So I'm assessing for history of infertility, assessing for history of painful periods, gut issues, autoimmune diseases. Those with endo have a higher likelihood of autoimmune diseases. So I take on mom and dad's side autoimmune diseases. So if there's even on the dad's side, there's like psoriasis and Hashimoto's, like, and so on and so
Mhm.
forth, like, that's just another indicator, oh, in my mind, oh, that could be endo. And then typically, I mean, we know that the ovaries start releasing hormones about 2 years before we start menstruating. So it tends to become more frequent within the 2 years prior to getting one's period,
Mhm.
but I see it all the time the mom will be like, "Oh, she always was constipated," or she always had bowel issues, or I had to take her to the ER because she couldn't have a bowel movement for 10 days, or there's all these subtle things in the history.
Mhm.
So, listen, tummy aches could be a kid not wanting to go to school. Tummy aches could be a kid who's,
Yeah.
moving. It could be a
Yeah.
lot of things. So I'm taking the whole picture and the family history, and there's so much information that I can ascertain from asking
Yeah.
the right questions.
Which is why, like we were talking before this, I feel like your education is so relevant for primary care
Mhm,
physicians. Because I really feel this early conversation needs to happen in a pediatrician's office
mhm,
or a primary care doctor's office. I mean, of course, at Sydenham, because we address gut health, nutrition, genomics, and we have the time to get into join the dots, and we are overly enthusiastic about bringing in specialists, collaborating, going to the root cause together. It gets done differently, but I guess people have to step up and take agency
mhm.
uh, to think differently about their own symptoms, I guess. That's the starting point?
Yeah, well, what happens with most endo patients is they don't even believe their own symptoms. So imagine the scene at home where the mom has
Mhm.
painful periods, right? And so the daughter thinks that's normal because she's watching the mom, or she's watching her sister have painful periods, or she's seeing both of them straining on the toilet or urinating frequently. So she's just like, oh, that's normal. So people have a different sense of what is normal. And also, it shouldn't be, but most people feel uncomfortable talking about their bowel habits or their bladder habits or sexual habits or their periods. Like, it's taboo, and it really shouldn't be taboo. We should
Or you
feel
just
so,
power through it.
yeah,
Like, okay,
that mentality
yeah.
of powering through it. And so, what happens, most of my patients, by the time they get to me, I'm one of the last stops, right? They have an 8 to 10-year diagnostic delay. Most end up having surgery with a OBGYN, a generalist, which is something whoever's listening, do not have surgery with a generalist. You really need a specialist doing the proper surgery called excision, which I'm hoping we'll get into in a bit.
Yes, of course.
But it's so it's just mind-blowing. By the time they get to me, patients don't even believe their own pain because they've been told, "Your ultrasound's normal, you don't have endo." That's most patients with endo, their imaging's normal. Or, "I examined you, you're perfectly fine. Oh, it hurts when you have sex. Have a glass of wine before you have sex." So the patient is being dismissed by doctor, by physician, by friend, by parent, by sibling, by partner. So they're
And by
so
themselves.
and by themselves. So they're so dissociated, they're almost out of their own body. So when they come to my office and I'm trying to get a history, I'm like, where does it hurt? I mean, listen, some people can say, oh, it's right here, or it's here, or it's here. But most are like, I don't know. My heart breaks for them. So my job isn't only, not job, because I do what I love. I'm passionate about endo. It's not only to help them heal and beat endo, hence the title of my book,
Yeah.
but I want to get them back in their body. I want to heal them from the inside out. I want them to live the lives that they were put on this earth to live.
Yeah.
So I have a big job cut out for me
No,
to like
it's
get to
so
all of those
it's
aspects.
so empowering. But can you first explain to us how it's diagnosed? Because it looks like there's no consensus even on how you diagnose it.
Mhm, mhm. So, first, I want to start by saying everything I learned in residency about endo and medical school was incorrect. So, and I was in a very prestigious program in Manhattan for residency, and I learned more in my first week of fellowship. And the two people who trained me were the world's leaders in endometriosis. So, in 1 week, week one of fellowship, I learned more than 4 years of OBGYN residency plus 4 years of medical school. So in 8 years, I learned less than in 1 week. So the point being is that
That so many people are going through fellowship and going through an education which is
they're
not
not
serving
learning,
them.
correct. They're not learning the facts about endometriosis properly. There's so much misinformation about endo. And imaging typically is negative or normal. And then the gynecologist who's armed with misinformation is saying, oh, your imaging's normal. You don't have endo. That's like so inaccurate and so incorrect. So the way that listen, there is better and better imaging. There's better ultrasounds where we can pick things up. There's better MRI, but it depends on the number of cuts. It depends on the machine. It depends on the
What are
reader.
you looking for in that ultrasound?
So on ultrasound, what I'm looking for versus what a radiologist is looking for, it could come back as normal, but I'm looking at the length of the uterus because an enlarged uterus could be endo in the muscle of the uterus known as adenomyosis. If I'm looking at the films, I can often see that the uterus is pulled to a side, but it'll be reported as normal. So I can see that it's on an angle, and that's because the endometriosis lesions are pulling it either to the right side or the left side or retroverted
Yes.
to the back.
So does everybody with a retroverted or a different verted, antiverted have endometriosis?
So if it's on an angle, like on the right side or the left side, and they have not had any surgery, it's probably endo. Retroversion is a normal anatomical variant. However, most endo patients have a retroverted uterus. It's being pulled back because most of the endo lesions, I mean, endo's been found in every organ of the body. Can be in your nose. You can have nosebleeds with your period. It's been in the brain, in the heart, right? It's not just a pelvic disease, but endo
Are these tissues or cells? Like,
there's cells.
okay.
There's cells that are similar to the lining of the uterus, and what's happening within the cells is it's releasing inflammatory mediators that are going systemically body-wide and affecting every organ system. So how do we even pick it up? For me, it's asking the right questions.
There is no like biopsy or anything like, or a blood test that can detect these cells?
So there's more and more tests coming out.
Mm-hmm.
If they're positive, it's likely that there's endo. If there's negative, a lot of the tests have a 20% false negative, right? So it's better than nothing. But for me and for my associate at Iris Wings, by history and physical exam, we can say with 90% likelihood that there's endometriosis. And then we make the official diagnosis at the time of surgery.
Yes. So now let's come to how do you cure endometriosis?
So it's a very simple question with not a simple answer, meaning because of the diagnostic delay of 8 to 10 years, but it's often 20 or 30 years, endo sets in motion a whole host of other things in our body. So if you imagine like the game of dominoes,
Yeah.
like endo's like the first domino that knocks down a bunch of other dominoes, okay, which I'll go into. So
Yeah.
we need to heal all of those, right?
Your book has done a really great job of really outlining all of those as well.
Thank you. So we'll start about surgery first for endo. So the gold standard for surgery is excision of endometriosis. Literally means it's minimally invasive, it's day surgery, but we're cutting out endometriosis. Endometriosis surgery is very complicated because endo can be found on the bowel, on the bladder, on all different organs, in the lungs, in the diaphragm, endo's all over. So you typically don't want a general OBGYN who's, in the OR maybe once a month or twice a month operating because they have a very wide breadth, but not much of a depth. At Iris Wings, all we do is one thing. So we have a very deep depth and a very narrow breadth. All we do is endo and minimally invasive surgery. So excision of endo is the gold standard. It's done. We do it robotically. It can be done laparoscopically, minimally invasive, tiny little incisions. But before I get a patient to the OR, I like to tune up their body. Okay, I look at it like I'm a athlete. I used to do triathlons. I didn't just show up to race day,
Right.
like ready to run. No, I mean, I ate well, I prepped, I trained, I learned the science behind nutrition. So the same thing is applied the way that I heal endo. So I'm looking for the coexisting conditions that often occur with endo. So most endo patients from being a little kid or when they get their period, they're curling up in a ball, right? And what happens is their abdominal muscles tighten. They are like squeezing and tightening their muscles. So I send them for pelvic floor physical therapy. This is not therapy at like a shoulder or knee person. This is a specific type of
Yeah.
pelvic floor
And
PT.
your co-author,
It,
Denise Stein.
yeah, she's a pelvic floor PT who I collaborated with when I had my practice in Manhattan. We know that one of the first places endo goes is the gut, right? The inflammation from the endo implant goes to the gut and causes a dysbiosis or leaky gut, small intestine, large intestine. And the foods that we're eating permeate through the gut and then the body starts attacking it, right? And we know all autoimmune diseases are coming from the gut. So I then work with the patients and refer them for integrative nutrition because we need to heal the gut because those with endo have a higher likelihood of autoimmune diseases. So tuning up the gut is so important. Those with endo also have a higher likelihood of having an entity called interstitial cystitis or pelvic pain of bladder origin. That's when they're like, oh, I feel like I got to pee all the time. I've seen a urologist. There's nothing wrong. My cultures are negative. So 50 to 92% of endo patients have that entity. So I'm evaluating for it. And if they have it, we help them manage it. And so on and so forth. Like those with endo have a higher likelihood of mast cell activation, Ehlers-Danlos, POTS, which is so common, long haul COVID. They have higher likelihoods of being sensitive to mold, which causes just like a whole body wide dysfunction. So whatever that may be,
Right.
we're
I had no idea because we work with all these conditions. All autoimmune conditions do fall into the Sydenham purview. But I didn't realize that this is something we should ask them to watch out for, that are their endometriosis symptoms getting better? And even post-surgery, do they have to keep up with these changes? Can it come back? Is it reoccurring or?
So my motto is one and done. Like that's my motto. Like I don't try and do a second surgery. About 10% of patients need a second surgery. Typically, those are patients who are desirous of fertility, and we're intentionally like leaving bits of endo because we want to preserve fertility. Or there's endo in the muscle of the uterus known as adeno. We don't want to touch that because we want them to complete childbearing.
Yeah.
So wherever we excise or cut out endo, it will not grow back there. You could have new endo forming. And that's why we tune them up with lifestyle, gut, we do surgery, and we have to continue those lifestyle issues because If their muscles have been tight for 20 years and they get to, let's say, 10 PT sessions before surgery, you can't undo anything in 10 hours, right? So you need to continue undoing that. If they have leaky gut or dysbiosis,
Yeah.
you can't fix that in a month or 2 months or 3 months. In my experience, it's like with my endo patients, it's a year plus to undo that. So we start tuning them up and then we continue on with that. So that's what we do.
So tell us, is there a relationship between hormones and endometriosis?
So the endo implants can there is a higher likelihood of estrogen dominance in those with endometriosis. The endometriosis, and then like the world, there's so many endocrine disruptors in the world that are and estrogen-like,
Right.
right? Like the plastics and all the things that are being put in food. And so the endo implants do respond to all of those endocrine disruptors, and it can worsen symptoms, that's for sure.
But would hormone therapy help
Okay.
in
Yeah.
those cases?
Okay. So what's so important, and like this is newsflash, I tell everyone, but what I learned in medical school is and residency is incorrect about hormonal management. I was taught first line. This is incorrect. I was taught first line that we give them birth control, that we give them medical management. We put in an IUD. We use
Yes.
Lupron. No, no, and no to all of it.
Oh
So
my God.
medical management just treats symptoms of the disease, but the disease continues to progress. So let's say someone has super heavy bleeding, it may lessen bleeding. If they have, level 10 pain, maybe it brings it down to an 8, assuming one can tolerate the side effects of hormonal management,
Mhm.
right? But the disease is continuing to progress. So that's where the common myth is, oh, I was on the pill and then I couldn't get pregnant when I went off of it. No, it was masking your symptoms of endometriosis. So you didn't really know what was going on. And then all of a sudden, someone who wants to start a family is trying to get pregnant. And they're like, I like, where did this come
Mhm.
from? But if you take a history, often
Mm.
patients will have a lot of symptoms before they went on the pill. So I'm not saying I'm
Yeah.
against it. It's a great symptom management while we're tuning up the body, but it's not instead of surgery.
And how does endometriosis play out, like, as we age as women?
Mhm.
Uh, does childbearing help? Does it get better with each decade? What does, like, menopause have to do with
Mhm, mhm.
endometriosis?
So there's a lot of myths out there that say, just have a baby, your symptoms will get better, or when you get to menopause, your endo will go away. So the implants are still there even during pregnancy. However, patients do feel better during pregnancy and then if they breastfeed, but as soon as they stop breastfeeding, the symptoms are back. Because you're not removing the lesions, which are causing inflammation, which are distorting and pulling the pelvic anatomy this way or that way
Mm.
or to the back, and then setting off a whole host of cascade affecting the gut and the microbiome. And then even women in menopause, the lesions are still there, right? Like they may be Miralax dependent. They're not recognizing that the gut symptoms are from endometriosis, that their extreme fatigue is from endometriosis, that their joint pain that's moving around is from the inflammation from endometriosis. So, yeah, maybe the symptoms may improve to a degree, but the patients are still suffering. And yeah.
So you could really be going right all the way up to menopause and never be diagnosed.
Yeah, I've operated on many like 50-year-olds or later. What happens is the mom usually brings the daughter.
Oh.
And then I operate on the daughter, and then all of a sudden in the consult, the mom starts talking about herself. "Oh, I'm constipated. Oh, I have SIBO, small intestinal bacterial overgrowth. Oh, I had 3 miscarriages. Oh, I have Hashimoto's and celiac. Oh, I have," and I look at them, I'm like, "I will open my schedule to see you. That sounds like you have endo." But the mom didn't know.
And after surgery, how does their life change?
The patients do typically do amazing. Now, I don't jump and operate on a patient who has a totally upregulated nervous system, whose muscles are
Mm.
so tight. I tune them up and I typically like to get them 30, 40, 50, 60% better.
Yes.
Lifestyle, eating, nutrition, gut, mind, body. I get them all to meditate. I'm like a
Mhm.
very Eastern doctor.
So, we do meditation here 6 p.m. every Monday. The
Really?
David Lynch Foundation,
Oh,
the office out of Sydenham. So, yeah, all this aspect of
oh,
Endo,
interesting. I love
Sydenham's
that.
got you. Like,
I
yeah,
love it.
this is how we work with our
I
patients. So,
love
this is
that.
going to really be a fruitful way to, show people that this is how you collaborate and
Mhm.
really work through. I mean, 1 in 10
Mhm.
is a big number
It's probably more common than that.
because of the other symptoms. Because 1 in 10 might be the classic painful
Correct.
period,
Yeah.
but when you combine the different effects it has and inflammation.
Because you need surgery for the actual diagnosis, so it's not like we're gonna take 1,000,000 women and operate on them, right, to
Yeah.
find the true number. If I had to guess, I've been doing this almost 25 years, I would say probably closer to 1 in 6. That's not
Wow.
founded on data,
Right.
but based on,
Yeah, you do
what I
mention
know.
that in your book that that's what you feel
Mhm.
it would be your number.
I don't even remember when I wrote that. Is
Yeah.
that what I said?
Yeah, I did.
I'm
Yeah.
glad I was consistent.
Yeah. Yep. Yep. Now, how do you differentiate endometriosis from fibroids or a thickening of the uterus line and other
Mhm.
common things that
Mhm.
you diagnose people with?
Yeah, so fibroids are growths of the smooth muscle of the uterus. So the actual muscle of the uterus is smooth muscle. So we can have fibroids within the smooth muscles. That's an intramural fibroid. We can have it like on the outside of the uterus. It's a subserosal fibroid, or we can have fibroids on the lining of the uterus in the endometrium. Those are the ones that tend to cause the heaviest bleedings. Those are submucosal fibroids. So both entities are common. Fibroids are common, like up to 30-ish% of women can have fibroids, and endo, like we were talking about percentage-wise, is still at least 10%. So two common things can occur commonly. I do see an association, however,
Mhm.
between fibroids and endo. Is it because they're two common things? I don't know,
Mhm.
but they are distinctly different.
What about PCOD and PCOS?
Yeah,
Like,
so
is
that
that something that falls into your domain or?
so, it's another common entity. I
Mhm.
think the percentage is roughly 10 or 12%. If I it's so not I'm so
Of like
focused.
comorbidity, like they exist together?
Well, they may exist together because 'cause they're two common entities. It's definitely not my specialty at
Or
all,
you
but
have
we
to
see a lot.
differentiate it
Yeah.
from it? Like, how do you differentiate?
Yeah, so this is so important, and I'm loving that you're bringing this up because a lot of patients come and say, "Oh, I've had so much pain and my doctor diagnosed me with what used to be called PCOS," right?
Yeah.
And I'm like, "Oh my god, we have to stop right there because PCOS does not cause pain." So most
Mm.
gynecologists are labeling someone with an entity that does not cause pain. Endo causes pain. When someone has the hormonal issues of what used to be called PCOS, they have irregular cycles, they may have facial hair, they may have nipple hair,
Mhm.
they may have like insulin, like a metabolic syndrome, insulin
Mhm.
issues, resistance. That is so different than endometriosis. Endometriosis causes pain. Like it's mind-boggling what OBGYNs are telling their patients.
The fact that you have a surgical cure for this versus you don't have a cure for
Mhm,
that
mhm,
is what would lead me for people to refer them to you to at least get it differentially
mhm,
diagnosed.
mhm. Yeah, we love those
Yeah.
referrals because what we love is to see patients beat endo and
Yeah.
like to re-inhabit their body
Yeah.
and live their lives. We love to see patients who have had infertility. They haven't been able to get
Mm.
pregnant. They're going through IVF, trying to get embryos. We operate on 'em and they spontaneously get
Mm.
pregnant. It's a very
Yeah.
common entity in our office.
Yeah. So maybe it sounds a little intimate for for a few people, but so when one of our patients went there, you know, our PA was with her even during the physical examination, holding her hand, and she said, "Oh my God, I've never seen any OBGYN do such a thorough physical examination." So, what is it that you're looking for? How do you do this so differently?
So I have to say, in my fellowship, I trained with Harry Rich. He did the first laparoscopic hysterectomy, and CY Liu. Again, like
Yeah.
fathers to me, fathers in the field. And it took me almost a year and a half into my fellowship, 2 years to even like just start understanding the physical exam. And then it's taken many years afterwards to really fine tune it. But first of all, I'm assessing them from the moment they walk in my office. Is there do they look inflamed? What does their skin look like? What is their posture when they sit in the office
Mm.
opposite me? Are they hunched forward, which most are, because the endo
Yeah.
lesions are causing everything to go like this?
Right.
Um, are they always like on a side like this because the endo is pulling things to a side? So I'm watching every motion that they're doing, like long before we step into the exam room. Then once I get them in the exam room, first thing I do is I examine their abdomen and I can find an asymmetry on the abdominal wall muscles because if the uterus, which should be right in the center, is pulled to this side, typically the muscles on this side are going to get tighter because they're like
Mm.
trying to work hard to put
Compensating, yeah.
compensating. Sometimes it is on the same side, but so I'm examining their abdominal muscles. I'm just looking at their posture. And then when I do a physical exam, I'm just visually inspecting
The internal
the
stuff.
external, internal.
Yeah.
And then when I put a finger in the vagina, I walk them through like what I'm going to do so they feel comfortable and they feel safe in the exam. But I put a finger in the vagina, and before I even touch the cervix, I'm assessing the pelvic floor muscles. And so I'll push on certain muscles and I'll see them. They'll say, oh, that hurts. So I'll say, okay, so far I've identified that the muscles are tight. And then I'll
That's
insert my
what.
finger. I'm okay.
Yeah.
I'm enjoying this peach day.
Oh, nice.
And then I push the finger in and I'm assessing for the cervix. And if the cervix is pulled either to the right side or the left side, it's probably endo because there's endo behind it in what we call the uterosacral ligaments that's pulling the uterus to a side. So then if I feel that the cervix is pulled, I then push in a certain area in the uterosacral
Yeah.
ligaments. And if I feel fullness and it reproduces pain, it's like higher than 90% likelihood that there's endo. So I'm looking for the endo there. As I feel the cervix, if there's a softness, it's usually adenomyosis or endo in the muscle of the uterus. Then I'm assessing for where is the uterus? Is it on an angle, which it often is? Is it retroverted? Is it enlarged? Then I'm trying to feel for the ovaries or the nexa. What do they feel like? Is it stuck behind the rectum? And then I'm also feeling for like levels of constipation because you can feel on a vaginal exam, you can feel like the hard, rock hard stool on the bottom of my finger.
Mm.
And like there's so much more. And then I assess the bladder and I'm assessing for interstitial cystitis. And so what I'm doing is as I push on the muscle and they have pain, I'm like, okay, that's tight muscles. When I push on the uterosacral ligaments and I think it's endo and it reproduces pain, I'm like, okay, that's endo. And I say, can you see how those are two different pains? And they're like, yes. And then I do the next thing. I'll push on the uterus. They're like, ouch. I'm like, that's probably endo in the muscle of the uterus known as adeno. Are you experiencing different pains from each one of these? I'm like, yes, no one's ever done an exam like this before.
Yes.
And then I go on and on and on for different things. And then I honestly always tell them, I can't listen when I'm naked. So let's put on your clothes and then let's go back to my office. And then I fully explain it. I want them to understand what's going on. And I break it down and we create a plan of what we're going to do to make them better. But physical exam, I have to say though, since COVID, I know how to ask the questions. I don't even need to do a physical exam anymore
Yeah.
because I've learned how we have patients from all over the world. I've learned how to ask the questions to get the answers without a physical exam.
And you've done a remarkable job of training other physicians too. Like, I know there's a male physician in your team
Mhm.
who is just, I mean, the level of compassion and care. Like, so it just goes to show that you're able to not only train women, you're training male physicians.
Yes.
And tell us a little bit about how you're doing this and what Iris Wings is and some of your other initiatives.
Yeah, so Iris Wing Sanctuary for Endometriosis Surgery and Wellness, it was born out of my logo used to be one wing, which
Yeah.
was just me.
Yeah.
And there was something when I became 50, I'm like, I want to make this world a better place. And I want a farther outreach. And as I was approaching 50, I'm like, I want to make this world a better place. And I had already had a PA. My PA was working with me. And I'm like, I want to create a center. And I took parts from all the different offices I've always worked in, and we created this beautiful center.
Mm.
We were featured in Forbes because it's very spa-like and very zen and calming, which for me is a very important part.
Cool.
It's very much like here.
Yeah.
And I then only wanted to create a family, much like I have my own family. I wanted to create a family in the office with people who share the same passion as me.
Mhm.
And when I looked for my first associate, I looked long and hard for many years because I needed to find the right fit. And my associate, Dr. E, is just wonderful,
Yeah.
wonderful. And, then we brought on a fellow, and I'm expanding with other physicians, and there's a lot to come, which I'll share in time
Of course.
with Iris Wings, how we're growing. And it's just, it's the human element and the
Mhm.
human touch and understanding the breadth and the depth of the disease
Right.
and, cre basically teaching people what I've learned in my 20 plus years. And, then we just train more and more and more people to help more and more patients because there's so many patients who need to be helped. So that's one initiative. Another, I'm a co-founder of the app Forella.
Mm.
Forella in Portuguese means for her,
Wow.
and we're creating it. It's actually like an AI health reasoning for complex diseases. We're starting with endo, and then we're going to go on hopefully to autoimmune diseases, and then hopefully going on for to like chronic fatigue, long haul COVID, MCAS, and so on.
Mhm.
But it's an app, and it'll be a user interface for patients. It'll be tied into usables, and then also for providers. And it's basically going to take all the fragmented care and layer it with different reasoning from all different specialists to help providers quickly figure out what's going on, and for patients also. So that is a passion
Oh,
project.
exciting.
Yeah, that I've been
So
working on.
before we end, we have a hot or not section where we
Okay.
just ask like what your views are on like some current trends. But of course, it's trending a lot nowadays about like maybe men having endometriosis. Do you want to shed a little bit of light on that?
Yeah, I mean, are you talking about men who are born men at birth or men who have
I don't
been
know,
transitioned?
you're seeing all this like stuff. Like
Yeah.
I only get my information from like memes and from Sarah.
Yeah. I'm not, I have to say I'm not on social media that
Yeah,
much because I'm pretty
yeah.
pretty busy. And I know but I do know that it's trending. I think anyone who was born female and then has transitioned, yes, of course that they can have endometriosis, right?
Yeah.
Because um but in terms of men, I don't think I can even comment on that,
Okay.
to be perfectly
Okay, great.
honest,
So a
but
few
I will
things
research it.
which we'd like for you to talk about. Do you think this is hot or not? Hormonal suppression using forms of birth control, is that hot or not?
And for me, not.
No.
For
Ignoring period pain.
not.
Pelvic floor therapy.
Hot.
Should we all be doing it, like even with or without endo?
Yes, I think anyone who's delivered a baby, anyone who's had a C-section, anyone who engages in their core, anyone who goes to Peloton, anyone who goes to Soul Cycle, anyone who is sitting on a bike seat, anyone who's doing squats and lunges, for sure.
Mm. What about having like preventive MRIs and ultrasounds for diagnosis?
I
Is that
think
hot? Like, are people doing more of it?
it's both and, like, there's such a value in it, but there's a limiting factor in
Right.
endometriosis. But yeah, I'm all for Pronovo and all of the different testing.
Mhm. What about IVF for endometriosis patients?
So it's both. Yeah. So I like picking up teens. I like assessing fertility in
Mm.
teenagers. I like being proactive and getting eggs banked and healing the mind, body, and gut so that they don't even need to do IVF.
Mm. Well, thank you so much for that. This has been first of many because I think there are many aspects of this. Because I know you break it down in your book. There is the whole physiology side of it, the fitness side of it, the pelvic floor, the tissue, the fascia. Then there is the gut health. And I really would love for you to have a conversation on camera with our nutritionist who's a gut therapist and discover something maybe new together. So
Love that.
look forward to having you back on Sydenham. Thank you so much.
Thank you.
Thank
Thank
you.
you.